Hi, welcome to MedLife. I'm Dr. David Wiseman, Director of Clinical Trial Center at Abington Neurological Associates, and this is Translating Science into Practice, Integrating Biomarkers, Real-World Data, and Patient-Centered Strategies in Early Alzheimer's, presented by Global Education Group. I'd now like to introduce my co-presenter, Dr. Justin Moon, Director of the Denver Neurological Clinic. Thank you, Justin, for joining me today. So these are our disclosures. Learning objectives for the sessions compare the available anti-amyloid therapies for early Alzheimer's disease by mechanism of action, trial outcomes, and administration considerations, knowing that there are no head-to-head comparisons, so we can't really know for certain the exact data. Evaluate initial real-world observations and guidance with the anti-amyloid therapies. Assess validated emerging biomarkers and the diagnostic tests that we use to support early and accurate diagnosis of Alzheimer's disease, and most importantly, initiate timely therapeutic interventions, and then identify how to implement patient-centered treatment strategies using shared decision-making to align these anti-amyloid therapies with the patient in front of us. This program is composed of 3 modules. Following this introduction, you're going to go to a video library page with all the available modules. Please choose the module you'd like to engage with first. Module number 1, how anti-amyloid therapies change the course of Alzheimer's disease. I'm going to take this one. First of all, these medications do not come from nowhere. They don't drop out of trees. There is a ton of phase 1, phase 2, and phase 3 work that goes into them. And with the approval of anti-amyloid therapies, there was actually, weirdly, a thought that this would somehow curtail innovation. But if we take a look at the Alzheimer's drug development pipeline, this coming target board, what we see is quite the reverse. There are more dots on this slide than ever before, and a multitude of mechanisms of action. So the future actually looks pretty bright, I would say. But let's talk about the ones that went from phase 1, 2, 3, and now are approved. Number 1, lecanemab. So the mechanism, it's an antibody given IV, and a couple of the antibodies get into the brain, and they bind to the protofibrils in the brain in somebody with Alzheimer's disease. And it was based on Dr. Lanfelt, who developed a monoclonal antibody against a mutated form of amyloid that forms protofibrils, but not into these enormous plaques. That was the genesis of that, as opposed to donanemab, which is also overlapping mechanism. But this epitope, what it goes after, is actually a modification in the plaque. So it only is found on amyloid plaques, and that's what it goes after. Okay, so slightly different. Let's talk about the lecanemab, the AD trial. It was done in about 1,800 people, predominantly women, as we would expect given the disease, mean age of 72. It was done across the world, 253 sites, and it was a randomization 1-to-1. They were not crossed. There was an open label at the end of a year and a half. People were randomized to either lecanemab, 10 milligrams every other week, or placebo, and the primary endpoint was this change in baseline relative to placebo in something called the CDR sum of boxes. There are many secondary endpoints, and we're going to talk about a couple of them. First of all, the secondary endpoint of amyloid, because if a drug is supposed to get rid of amyloid, and on PET scan it does not, then that drug is in deep trouble. Now for lecanemab, what we see here is it treated people over the year and a half, 18 months, the amyloid is lowered, and it's lowered by about 50 centiloids at the end of the day relative to placebo curve that kind of ticks up a little bit. And that is associated with CDR sum of boxes that shows slower progression. So the people who were randomized to placebo and they were coming in every other week and they didn't know that they were on placebo got worse in accordance with their disease. And on the CDR, they lost about 1.5 points over a course of about a year and a half. But lecanemab, you can see at 6 months, it sort of bent them upward, and they did better relative to placebo. So patients say, how do I know it's working? How do I know it's working? Well, you're not going to be able to see the path not taken. But we know from other humans that went through this process that you're better than you would have been. And the time saved is what patients really glean onto. Because if bad is sort of below here, we're preventing badness from occurring and keeping people a little bit flatter than they would have otherwise. I think both of those things resonate with patients. When I was initially counseling patients, I was struck by the fact that they were like, I want to get rid of amyloid. I'm like, that's great, but we really care about how you're doing clinically. But the patients have kind of convinced me that this is a valid thing. You know, they feel polluted or burdened by amyloid, like it's a toxic thing, and we can say we can get rid of it now. That's a good thing. I don't know if that resonates with you, Justin. I found that to be something that patients really are after.
Absolutely.
Yeah. So when I was in the audience when they presented this data, you know, they're talking about every single secondary outcome measurement, cognitive measurements, and functional measurements, and a lot of biomarker data. But this is what really stuck in my mind. This Zaret burden interview, which is a measurement of how burdened a patient's caregiver is by them. So it's a handout that we give the caregiver, typically at the end of a pretty long day. And you see that the lecanemab caregivers are less burdened than the people on placebo. So that really struck me as being like, oh boy, wow, that's really impressive. Not only is it positive in its primary outcome, but its secondary outcome, but also this Zaret burden interview. I mean, even the caregivers could see the difference here in terms of how burdened they are. Okay, so since the original data, which if you look here at the very far, like at the middle left, and that showed the change in the CDR. After that, the placebo people got the drug. So they no longer are a comparator. They can no longer serve as a comparator. So what the company did is they followed the people who were treated, and that's the blue line. They're initially treated, and then they continued to get treatment, and they compare it to historical controls, because that's really the best you can do. Now, what happens to the placebo people, when they start the drug, they never catch up. So it's a very disease-modifying look to the data. But when you look at the historical controls, you see widened gap over time. Small differences early on can be sort of tossed aside, and a lot of people have said this is not enough meaningful change. And with respect, they're wrong, because it's a 1.5 year study in a disease that can last 15 years, give or take 10 to 20 years, even longer than that sometimes. So over time, these changes accrue between, again, the historical control and the treatment group. And at 4 years, the slowing of decline is sizable, okay? We're learning more from these long-term treatments, and particularly among patients with low levels of tau. And so Alzheimer's disease is amyloid and then tau and then neurodegeneration. So people who are earliest in the disease, as measured by tau, do better. And at 18 months, sustained through 4 years of treatment, 69% of that population is a subgroup. So, you know, it's not statistically, it would be statistically kind of illiterate to say this is very true. but it's provocative data, and it tells a story that time is brain. And because we see this across the antibodies, that's what many of us have come to believe, that time is brain, because these people do particularly well, no matter how you measure them, on the CDR, on ADAS-Cog, or ADCS, which is a functional measurement. So real-world insight, this is 15 neurology clinics, really from across the United States, had the following patients who cannot be compared to a placebo group because there was none. This is just real-world data. And they were predominantly female, and homozygous people were 19% of them. About 10% of them had a microhemorrhage. The average microhemorrhage was 1. Many of them had baseline white matter hyperintensities. And what you see when they followed up, and this data is incomplete, it will be completed by this winter, 71% had not progressed to the next disease stage. And actually, some people had improved from mild Alzheimer's to MCI. They had actually gotten better. Their clinical stage had gotten better, whether from test-retest phenomenon, the drug, other symptomatic drugs. There are a lot of confounders here, but that's the data. The stage actually got better on people on treatment. In terms of safety, ARIA, 10%, 10 patients had ARIA events. ARIA-E was 8, and ARIA-H was 2. And then 6 patients experienced adverse events resulting in discontinuation. Mostly ARIA. Discontinuation was just driven by a wide variety of factors. For those on anticoagulation, no abnormalities or ARIA for the people on anticoagulation. And antiplatelets, 11 had white matter hyperintensities, 1 had microhemorrhages, and no cases of intracranial hemorrhage were reported. So what's kind of new in town is this maintenance dosing of lecanemab, going from every other week IV, and after a year and a half, now it's a decision whether to stop treatment, that's an option, or go into IV monthly or subcutaneous every week, and that can be given at home. And so far, personally, my uptake of the subcutaneous has probably been about 50-50. I see a lot of people from pretty close, and they don't mind coming in. It's kind of a social visit for them, and they love the nurse. So sometimes it's weird, like subcutaneous, they don't really want that. They don't want a needle every week when they can come in once a month and have that sort of group session. Justin, what's your uptake been?
We have about a third of our patients going to the subcutaneous injection. So our patients are slower to gravitate towards that.
Okay. So turning to donanemab, the other drug, this is the one that binds to and removes plaques out of the brain. It was studied in a very similar way. Again, about 1,800 people, mostly women, mean age 73, randomized 1-to-1 to either donanemab or placebo. Many widespread locations, 177 sites, and the primary endpoint was different. It was this thing called iADRS, and a bunch of secondary outcomes that were pretty much the same. And here's the change in amyloid, and exactly what we saw before with the other drug. With lecanemab, we saw drop in amyloid, and with donanemab, we see the same thing. This is they kind of went into the weeds a little bit. They had a combined population on the right and a low-medium population on the left, and you see the same thing, that you are delaying progression. Regardless of how you slice and dice this data, the separation is apparent early on and then continues over time on their primary endpoint, the iADRS. And again, kind of same conversation we have with patients. And they also had this long-term extension data where we see lower risk of progression in the next disease state, and then early start do better, delayed start do worse. This is another way of, this is a different titration schedule. The initial titration schedule had ARIA and this is a risk factor of all the drugs. We're going to talk about it more. But with a modified titration, we saw less ARIA-E in a different trial. As you see, there no ARIA on the right is common, and there were no cases of severe ARIA symptomatically with the new titration. So that was very quickly adopted and is now part of the label. So the administration-related considerations, I have a version of this handout to my patients. The donanemab is once a month. It's less burdensome. You can stop it after a year and a half or with clearance of amyloid down to below negative. And lecanemab, you don't stop it. Okay, there's no firm stoppage criteria, and it's more burdensome with once every other week. But at the end, you can go onto the subcutaneous injector, okay, once a week. Now we're going to talk about ARIA. So it stands for amyloid-related imaging abnormality. We already talked about amyloid. Amyloid builds up in the brain, and then it builds up into these little tiny blood vessels. And we don't know exactly why, but it makes them friable and fragile. And spontaneously, we have now seen leaks that occur, either plasma or blood getting into the brain. That can happen spontaneously. The drugs, by removing amyloid out of the blood vessels, make that more likely to happen. So that's a class effect of these drugs, okay? And the patients, when they get ARIA, which is seen over here, ARIA-E up top with diffuse fluffy white matter hyperintensities and subcortical hyperintensities, and it can drag out these little bits of blood, hemosiderin, that kind of tattoo the brain. What we do is when we see this, we hold it, because very likely they're not going to have any symptoms. We monitor their MRIs before certain doses. When we see the ARIA, we give the patients and their caregivers a call. And the number one question they have is, when do I get back on treatment? Because they're pretty motivated to continue. So one of the things that I've been telling these patients is, if you think about it, one of the hurdles to get these drugs into the brain has been the blood-brain barrier. And with leakage, we're getting a dose into the brain. So it has been shown that we've co-localized where the ARIA is with a later PET scan that shows pretty good deep removal of amyloid. So they don't have to worry so much about that. There's a little bit of a silver lining with this ARIA, in that it gets the drug into the brain. But we want to keep people safe. That's paramount. And I definitely do not want to underplay ARIA. And the way to keep people safe is you get the MRIs before certain dosing. And if they get the ARIA, then hold the dose. And if they're symptomatic, we can give them steroids to kind of help them out. And it firms up their blood-brain barrier and less ARIA. Okay, so when we take a look side by side, the overall ARIA risk, ARIA-H and ARIA-E, is just lower with lecanemab, more burdensome, but the trials show less ARIA-E versus donanemab, the original titration. This is probably lower, but it's not broken down by ApoE because the numbers are just too small. Okay, so another way to keep people safe is by getting a baseline MRI. And so if there are 4 microhemorrhages, then it's okay to dose people, but be careful, because any microhemorrhage past 1 increases ARIA risk. And certainly this thing, superficial siderosis, which is basically a microhemorrhage that kind of exploded on the outside of the brain, the subarachnoid space, those are dangerous, okay? So if you see 1 or 2 of those, that's something really to consider. Maybe this is a bad fit for the patient. You don't want to put people in harm's way. Use clinical judgment about risk and discuss this risk tolerance with people, because the drugs on one side are not a panacea. They're good, they're not a panacea, but a bleeding event or ARIA or significant ARIA, it could have consequences. So, I mean, again, we have to kind of be mindful about risk and benefit. This is a very good case to look at, because this case was missed. This happened to me. This is a case of ARIA that is just barely perceptible. And I would not have been able to see this, honestly, moving prospectively. It's only when the patient was redosed and got pretty significant ARIA, maintaining asymptomatic throughout, zero visual field problems, zero headache, multiple conversations with her and her care partner, no problems. But when you look back, you see a little smidge of ARIA. So even though it's permissible, and the FDA permits to dose through minimal ARIA, mild ARIA, I would encourage you to not, because you don't know what direction it's taking. It could be getting better. It could be getting worse naturally. But if you dose through it, you could be making it sort of explosive. Now, this patient was unharmed. They totally fine. The ARIA resolved, no problems at all. But again, it could have been a problem. Okay, so random, just pearls and pitfalls, things that I've learned. Please learn from my mistakes. This was read as a possible contusion. Okay, in the setting of what you think of amyloid disease, Alzheimer's disease, this is not a contusion. This is superficial siderosis. It just looks like a frontal blow, but it's not. And even if it was, it doesn't matter. Okay, because you can't tell the difference. There is a tip-off within this MRI that this is due to amyloid, and that is here. There's a tiny little microhemorrhage right there. And so that microhemorrhage was called, and then the contusions were thought to be old, but be careful. Look at your MRIs, and especially in their weird things, okay? And then obtain a recent MRI per FDA. Appropriate use says a year, but be judicious. If it was 9 months ago and the patient is APOE4/4, they had 2 microhemorrhages 9 months ago, that's not fully reassuring to initiate anti-amyloid therapy now. And know when ARIA occurs. So this is a terrific chart. It's stratified by APOE4. APOE4/4 people have the highest risk. 1 copy of APOE4 lower and no copies lowest. Placebo, I guess, is the lowest, but still happens. And what you see is ARIA is front-loaded. ARIA occurs in the first months, okay? It can still happen after 6 months, but it's very rare. So a headache with like a weird visual problem here, probably ARIA. A headache plus a weird visual problem here in an APOE3/4 patient, probably not ARIA. So have your antenna out early. Later on, still use judgment, but kind of know the probabilities here that you're dealing with. Expect worsening. I do my best to explain the data, but I still hear patients say, why is this drug not making me better? Because it doesn't make people better. It slows down progression relative to placebo, either drug. And then no TPA. So the bottom here shows a really unfortunate case of a person who was on anti-amyloid therapy, appropriately was treated with TPA, and had very friable blood vessels, as you see here, with inflammation. It was very likely due to the drug that may have loaded the gun, but TPA may have pulled the trigger onto these multiple macrohemorrhages and ultimately death. So we've taken that case and made a law, no TPA, especially within the first 6 months when ARIA is most likely to occur. Endovascular treatments still appropriate, but TPA probably off the table, especially early on. The ARIA risk factors, APOE4 is the greatest risk. Okay, so those people are at the greatest risk, and they really require special counseling. People with APOE4/4 have seen the disease in their family, their parents, and aunts and uncles, even brothers and sisters. And I've actually had that. My patients have said, I saw my older brother go through this, and they don't really, and they're very risk tolerant, possibly. So just have risk tolerant discussions about them. Again, any microhemorrhage has to be taken into the context of that patient. Prior strokes, also a bit of a risk. Okay, so the guidelines, we newly released recommendations on MRI protocols, basically 3 brain sequences. We want to get a flare. We want some way of looking at blood, either GRE or SWI, and a diffusion weight, a DWI sequence to monitor people while they're on therapy. But really the most important thing is to get the scan and have it signed off on before they get the next dose. This is what I was talking about before with mild ARIA-E. The FDA says you may continue dosing, but clinical judgment, you may want to overturn this and just make certain that the ARIA is staying mild, okay? Or hopefully a month later it'll go away. For everything else, suspend dosing and wait for ARIA-E to go away and ARIA-H to maintain stability. And then you can discuss going forward and redosing. Thank you, Dr. Moon, for joining me and engaging in this insightful conversation. I'd also like to thank ASI for their support in this important educational activity. If you have not yet watched all the modules in the activity, you'll be directed to the video library page to continue the next module you'd like to watch. You must watch all 3 modules to receive credit for the activity. Click the next button to move on and select the next module you'd like to watch. If you've already watched all the modules in the activity, press continue to continue the post-test and evaluation. Please remember to complete the post-test at the end of the session to secure CME. Visit medlive.com to view today's session along with other sessions. My name is Dave Wiseman. Thanks for joining us.
Now the question is, as the science advances, how do we meet those challenges moving forward as clinicians? And so we're going to talk about applying the biomarker science in practice, advances in early Alzheimer's detection and diagnosis. So how should it go? It should look very linear. We should take a history and physical. We should make a clinical suspicion. We should try to stage the disease and assess the patient. We should do a workup, MRIs, labs, introduce blood-based biomarkers, and then consider more advanced testing, lumbar puncture or PET scan, make the diagnosis, discuss treatment options, and then monitor those patients throughout their treatment. What it really looks like is this. It can be a mess out there. We don't get accurate information. We don't get a lot of family support. There's delays in the workup. Patients have fears. They don't show up for appointments, family issues, insurance denials. So it can be a tough challenge. Over the last 4 years, we've been dealing with these challenges with our various therapies, and we've had to fight through a lot of these. And even as we get better with this and make this more formal, we still have these challenges, and all of you will have some challenges moving forward. So why? Why is it important for us to detect early? 20 years ago, when we were dealing with Alzheimer's disease, it was a delay move. We would see the patient, we would have suspicion, and then we'd say, let's see you next year. Let's see if you get worse. But we all know that what is critical in advancing, disease management is to get those patients early, and therefore making a call early, because we need to rule out reversible causes. Now that we have therapies, we need to initiate these therapies early. But identifying disease also helps those patients give options whether or not they want to enroll in clinical trials and make advanced directives and planning for their future. So it's very important, as now that we have treatment, that we prioritize those patients who potentially could get treatment. Yes, we too have those patients that come out of the woodwork, living in nursing homes, now necessitating evaluations, even though they've already lost independence. Yes, these patients are important, but these are not candidates for treatment. So we really need to look at these patients and identify these candidates early. And so when we looked at those patients, when we looked at criteria for lecanemab therapy, looking at many mental status evaluations, 22 and up, and donanemab patients 20 and up, we need to get them early. We need to get them at CDRs, globals, at 0.5 to 1. And we know if we wait that some of those patients will fall out of that eligibility. Those patients with a CDR of 1 often will lose eligibility by 12 months. So you are on the clock. When they looked, however, at patients at the NACC and the ADNI population, and I think the NACC was roughly 1,500 patients, almost 2/3 of them were eligible for either lecanemab or donanemab. And I believe the ADNI population was about 1,000 patients. So again, about 2/3 of those patients eligible for lecanemab and donanemab, meaning that if we look at those patients carefully, many of them will qualify for potential treatment. So how do we do that? Yes, the clinical evaluation is important. Yes, doing an MRI is important, but oftentimes we will get something vague, such as age-appropriate volume loss. And then we may do memory tests, and we have to take in consideration, education level and age and so forth. So sometimes we get some vagueness of whether or not the person has actual disease. And when we think about dementia as a whole, Alzheimer's will represent anywhere between 60 to 80% of that population. So how can we confirm those patients early versus thinking about them as possible frontotemporal dementia or a different disease state? That's where the biomarkers come in. In the February 2024 New England Journal, there was a longitudinal analysis of a population in China, 20 years of data, identifying CSF biomarkers coming abnormal up to 18 years prior to a clinical diagnosis. That is 18 years. Now, we don't all check spinal fluid in every patient that we have any suspicion of memory, but now we have blood biomarkers available that make it easier for us to test those patients. A-beta 42, 40 ratios, the p-tau, the total tau, the NfLs, and we have potential markers in the future that we will be looking at. So what's important is to know that how disease progresses with Alzheimer's and the role of protofibrils in this disease state. So Noguchi did a study looking at individuals who don't have disease on the left, those who have clinical impairment but negative for Alzheimer's pathology, and then those with positive Alzheimer's pathology on the right. And what they did was they traced the lecanemab, which binds to protofibrils, to see the rate of protofibrils in these disease states. And what you'll see here is a correlation. As people have clinically positive and biomarker positive disease, you see a higher rate of protofibrils, which is the targeting point of lecanemab therapy. And so biomarker testing in clinical practice is now available nearly everywhere that we start. To give you an idea, in Denver metro area, we did not get amyloid PET scan until 2023. Now we have several centers that are able to perform PET scans for us with amyloid tracer. Most of your major metropolitan areas will have this available. There are 3 different types of PET scans that can be performed, and they all have very good sensitivity and specificity at 88%. Now, the tau PET is a newer phenomenon. Not every community has this, but this is something that will be spreading, and you'll be hearing about this in research trials. Spinal fluid analysis came out in 2021, and that's when we started using it here in Denver. And this is available to most centers across the country, as long as you can perform CSF testing. And the blood-based biomarkers. Now, FDA approved for the diagnosis of Alzheimer's, but we've been using these as guidelines for screening purposes for the last several years in our patients. So then comes to the biomarkers, the Lumipulse, amyloid plasma ratio. So this looked at patients, adults over the age of 55 with signs and symptoms with Alzheimer's disease, and it's a ratio of p-tau 217 and A beta 42. And based on this calculation, we get about a 91% sensitivity to the disease and 97% specificity to disease. Now, about a fifth of the patients, however, will have an indeterminate ratio. So you can use these tests if they're 90% and 75% as screening tools, or you can use them as diagnostic tools for your patients to advance treatment. We generally have a preference of using these as screening tools and using a secondary tool such as PET scan or CSF testing for confirmatory purposes.
Thank you, Dr. Moon, for joining me and engaging in this insightful conversation. I'd also like to thank ASI for their support in this important educational activity. If you have not yet watched all the modules in the activity, you'll be directed to the video library page to continue the next module you'd like to watch. You must watch all 3 modules to receive credit for the activity. Click the next button to move on and select the next module you'd like to watch. If you've already watched all the modules in the activity, press continue to continue the post-test and evaluation. Please remember to complete the post-test at the end of the session to secure CME. Visit medlive.com to view today's session along with other sessions. My name is Dave Wiseman. Thanks for joining us. Now switching gears into applying this care via personalized treatment decision making, which is something that we can actually offer with the trial data. With the trial data, we can actually personalize risk into 3 main buckets. But before we do that, what are we trying to do? Like, what's the overall thing? It's still, believe it or not, a little bit early days. I don't think we're almost 3 years into the approval of lecanemab. What we're trying to do is still take the trial ideals that kept people really safe for lecanemab and implement those into clinical practice. And how to do that? Get the right patients. So that means that there are patients for whom this is not the right therapy. You have to say no. This is not a good fit for you, either because of informant, caregiver reliability issues, MRI problems. The MRI, if it shows 3 or 4 microhemorrhages with a bit of superficial siderosis, then you have to use clinical judgment and say, listen, I don't know if this is a great thing for you. We can get ApoE, and even if they're ApoE44, if they're super risk tolerant and their MRI is clean, then we're ready to go. That would be a right patient. And then, of course, a reliable caregiver, they're so important. Monitoring. They must have an MRI, as I alluded to before. As you see over on here, before dose 5, they must have an MRI done, and it must show no problems. It doesn't mean a fellow giving me a call. It means a written report that I have seen and I have signed off on. That is a negative MRI. Okay, nothing less should suffice. And risk management. Now we've learned so many lessons about ARIA and how to put that into context of a fatal disease. And then I really want people to learn the right lessons. And I love this quote from Tupac. It may have been Mandela. I don't know if he adopted it from that or not, but he may have said it. I love it. Trust me, I never lose. I either win or I learn from it. So better to learn from my mistakes, better to learn from mistakes made in the clinical trials. But also, when you iterate this stuff, learn from it. Okay, this patient didn't do well. Why? Okay, and then how to implement on the scene, use what you have. I tell this joke, when did Noah build the ark? Justin, you know this one? When did Noah build the ark?
Before the flood.
Before the flood. And it's funny, like out of context, nobody gets it, right? But within this context, if there was a fear that we're going to be flooded by people with Alzheimer's disease seeking treatment, and of course that never happened. It was always a trickle. This is a stigmatized disease. Patients don't even know that they have it. It's not disclosed. It's not even diagnosed. So, but when you're implementing this, use what you have. Do not build a new wheel. So you already have good clinical sense. If you don't have it, you can learn. You have inclusions and exclusions. Develop those. Get a sense for good fit, bad fit. Labs. You have a lab facility. I've started using blood-based biomarkers to decrease my door to needle time and to keep my PET scan, you know, open for other stuff. MRI, you need the MRI. You need to talk to radiology. I initially was doing a ton of LPs, and you need admin because with no margin, no mission. And that goes for academic or private practice or whatever your situation, institutional. You need admin people to make it work, to make the salaries work. There are going to be people implementing this drug, people dosing the drug, and they take salaries. Staff, you might need more doctors, PA, nurse practitioners to implement this. MAs, we have MAs, we have reception, we have schedulers, we had an infusion room, we were dosing ocrelizumab and tysabri, and now we just increased it. We increased the volume with anti-amyloid therapies. We developed a tracking system, which you see here, and then you have to fight the good fight. You may have internal stakeholders in your institution who are basically saying, no, it's too risky, we don't want to. You got to fight. And you certainly got to fight against insurance. Those are external stakeholders who are not getting paid for writing checks. Okay, optimally, we would adopt shared decision making. In patients, and just, I'm sure this happens to you, when they come in and like, what do you think is best? And based on their age and where they live, you're like, I think this is best for you. And they're like, okay, great. Well, in that kind of situation, you're not going to have a shared decision making. They share decision making up to the point of treatment, but which drug to get, they're asking you for guidance, right? And I totally appropriate to say, I think that this is a good fit for you. You live 5 minutes away. Every other week is fine. You have 2 microhemorrhages. We decided to treat you. Let's treat you with the perhaps less risky option, although no head-to-head things. But ultimately and optimally, many times it's a shared decision making where we're coming together and really considering treatment options or deliberating. I love it when patients actually don't decide right now and they bring it home and let me know. And we make an appointment in like a week. And then it's a pretty quick appointment because they've already decided by that point. What's their life goals? I mean, this stuff gets real. A lot of people want to see their grandkids grow up. They want to see the grandkids and be part of their life or even their children. What do they want and how to get them there realistically? And really setting expectations is probably the most important thing because we're going to see them decline. And if that is a surprise to them, I feel like I haven't done my job well. So choosing which treatment is best together, and no treatment could be the best option for them. That is acceptable. And then determining if the response is to treatment goals as it goes on, and realigning the treatment as necessary. If they have a pretty significant infusion-related reaction, what to do then? We pre-dose them, it happens again. Then we pre-dose them with steroids, and maybe that gets better. When to stop the steroids? Iteration always has to occur. This is one of my slides that I love because I stole it from obviously the far side, who is adored by me. There is this perception of risk among doctors, and early on, especially the doctors were left shifted. They were risk intolerant. Many doctors are like, I don't want part of this. It's not enough for the hassle or the risk or whatever. But for those people, I would just say, listen, adopt the view of a patient because the patients are in the deep blue sea. And if they're looking at ARIA, and that's fearful, and it can be bad, consider their alternative, which is not great, right? So this is really their only safe harbor. It's something they could do to bend the course of their disease. And if they're very aware of ARIA, so very fearful, that's totally fine. But it's really important to be permeable when they're not afraid of ARIA. Patients and caregivers will say things, and I've heard this, these are direct quotes from my patients. I will do anything I can to delay progression. I don't care about that, ARIA. I want to die before I'm a burden. I want to die before I'm a burden. No, it's a lot. As a person who's probably seen the disease get really bad. But some people are on the other side. Patients are like, nope, thanks, but no thanks. No, I will wait for a cure. I think that informed consent, they need to have the information to not consent, to not do it. They have to have the information about what they're dealing with, the natural history of this disease. And then, sometimes it's in God's hands. It comes up. And then I've asked, would you do chemotherapy for cancer? Of course I would. So yeah, again, like informed consent, we think about informed consent for somebody signing on to something. I really think that patients who say no need to, especially to be informed about what they're signing up for as well. No doses. Well, here's a patient, 64-year-old man, MCI due to Alzheimer's disease, married 38 years, 3 adult children, employed as a teacher, planning to retire in the next year. His medical history is very bland. Family history is significant for maternal mom, late onset dementia. His main mental is 22, but his CDR is really good, 0.5. Neuropsychiatric findings are consistent with MCI. Blood-based biomarker, he's positive. Brain MRI, mild hippocampal atrophy, no vascular disease. 2-year progressive short-term memory loss, noticed at work, increasing difficulty managing things, managing finances, but remains independent, doing everything. So pretty classic MCI due to amyloid. So here's the discussion points. He believes, and his wife believes, that these are just normal aging. They've noticed these mild changes among their friends. So question, Justin, what evidence would best to share with Jay and his wife to support a diagnosis of MCI?
I think in this kind of scenario, showing them visual evidence is very important. It starts by looking at that MRI to show that there are signs of atrophy and signs of aging on this brain. And then to bring in the blood-based biomarkers, which are abnormal, in this case, giving us signs that we are at the beginning stages of disease. So I think that those things are concrete and can be very helpful for patients and families to move forward with accepting a diagnosis.
Yeah, I mean, I've had these conversations myself, and I'm like, you came to me with a concern. Like you're kind of negating your own self, right? The concern was memory loss. You came to somebody waving your arm. I have a chief complaint. You went to your primary care doctor. You came to my office. It's very difficult to get to see me because of the stigma of the disease. And trust yourself. And I give you these 3 words, and it's not normal. And a nice way to say it is, your memory is not what it once was. So even in part of the disease can be denial of illness. Anosognosia happens in all neurologic diseases, including this one for sure, maybe even more than we typically see. So the denial of illness and a spouse, it's a common disease, and it's thought to be due to attention problems and normal aging, but that's really part of the stigma of this disease. Second opinion could help such a patient, but time is brain too, so that will delay things. I agree with you that the biomarkers can be helpful in this situation. There's no accident that we checked you for this amyloid stuff, and it was positive. So what are we going to do about it? And opening up that conversation. I've had a patient who drew my cubes, which I actually have behind me, improperly. And his wife said, well, he could have drawn that like that 5 years ago. I'm like, no. There is no way. I refuse to believe it. Okay, so a data point would be helpful to support the diagnosis beyond a cognitive evaluation. I mean, there are many tools up our sleeve we could use here, but I think further discussion and putting it all into context. Okay, so once they understand the results of the testing, they're ready to discuss potential management strategies. Before discussing the details of treatment options, are there imaging data that would be useful to complement his biomarker profile and determine a treatment path? And just to remind ourselves, it looks like he's had a brain MRI, blood-based biomarker, and then the only thing I see lacking is ApoE. What would you do?
So this is where an additional test like the PET scan would be very useful. We've already set up the discussion saying we think that there's a clinical problem. We see some biological correlates, including the blood-based biomarkers and the MRI. And now we give them a little time to digest that information and to say we have one more data point that we could do. And a positive PET scan could underscore that diagnosis and make it more acceptable to the patients to move forward with the diagnosis.
I would agree in part. I think for him and his wife, they might be people who really require a PET scan to see it, to believe it. But I would just put out there that blood-based biomarkers are so good now that in the proper clinical context, they're ready for prime time. So if there weren't this sort of discord between them and what we see, I would say the PET scan is not necessary to move forward. A PET scan would be necessary for commercial insurance. They're not really accepting them, or at least I'm scared of it. But depending on insurance, if he's Medicare, it would be appropriate to just move forward with ApoE. Okay, well, you nailed it. PET scan shows amyloid. We discussed with Jay and his wife that he is eligible for one of the anti-amyloid therapies. They both expressed concerns about side effects and the burden of monitoring. Next best steps. Discuss benefits, risks, and monitoring requirements, patient and family preferences, lifestyle modifications, defer biologics to a later stage, cholinesterase inhibitor instead of biologics, advise them that they have ample time to think about the treatment, discuss it again, 6-month follow-up. Justin, you're up. What do you think?
So it can depend on, where the patient and families are in the clinical stage and their stage in accepting the diagnosis. But clearly, you don't want to wait too long, okay? Right now, you are on the clock. The patient is on the clock. And every year that goes by, you potentially lose eligibility for treatment. We don't have any issues with lifestyle modification or additional therapeutics, but we really want them to understand that they have potential options of treatment, that they need to discuss the risks of these treatments and tell us as the provider what they want to do and what they're willing to do moving forward.
Yeah, I would just say that A is obviously the best choice, and then B and C are both compatible with anti-amyloid therapies. Okay, so yeah, if you're a believer in lifestyle modification, which I am not, you can do that. Okay, I encourage people to exercise for general health, and maybe it helps get rid of amyloid a little bit. I'm underwhelmed. High dose cholinesterase inhibitors, fine, but certainly time is brain. See in 6 months, that's the wrong answer. And listen, discussing it, they may say no. This may not be a good fit for them. That's okay. But at least they've got a shot on goal. And you should document that they do not want to proceed with anti-amyloid therapies, because in a year, they could be sorry.
So let's get to the second case. This is Doreen. Doreen, 72. She's had some memory issues for the last 3 years, but an official diagnosis of MCI 7 months ago. Now, she's got hypertension like many of our patients do and is on amlodipine, but she also has atrial fibrillation, which is very important. She has mild chronic kidney disease and is a former smoker. The mini mental status evaluation is at 22, which fits within our guidelines. She had a brain MRI with mild hippocampal atrophy, an abnormal PET scan, and she is homozygous for ApoE4. So Doreen and her daughter expressed concerns. They're worried that they can't get her to all the appointments, the MRI scans, the clinic visits. Daughter can't continue to, take time off of work. She explains that her mom is doing so well that maybe she doesn't need those MRIs. What's the most appropriate thing to discuss with Doreen and her daughter given those concerns? How would you handle this, Dave?
I have handled this. I feel like I've seen Doreen and her daughter quite a bit. And, this is not for everybody. If we cannot commit to the therapy and the burden of the therapy, then it could be a disaster. But is it possible that you could think a little bit outside the box? Doreen sounds mild. Doreen can probably get to the infusions by herself, especially if she lives close. The daughter should be available, but she doesn't need to accompany her. Ditto with MRI scans. We can do a lot of this stuff with help. If these people have cognitive impairment down the road, maybe she won't be able to do it, but maybe she will be able to do it. Maybe, again, think outside the box in terms of friends and family. Are there other people who can step up, right? Neighbors. I mean, people are good. And if you ask for help, people can give it.
Yes, and it takes a lot of clinical judgment and experience over time to kind of determine what you are comfortable with as a clinician. For us, we've tried some of those alternative methods of having friends and neighbors commit, but they just don't work as well as a committed family member. So we really require in our clinic that family is committed moving forward, or we don't advance some of the testing. And one of the things you can remind her is she could still change her will at this point. So maybe Doreen's daughter needs to kind of comply a little bit here. All right. Next, on her routine MRI, Doreen shows evidence of mild asymptomatic ARIA-E, but also evidence of superficial siderosis. She reports only mild headaches that are self-limited. What is the best management strategy at this point? And if you saw earlier, Dr. Weissman showed us a protocol, if you will, for what to do in the case of ARIA. And in this kind of case, with the superficial siderosis, it necessitates a pause in activity. So we would stop infusion and clinically monitor the patient. She not only has ARIA-E, but she also has clinical symptoms. Therefore, pausing the infusion and watching for clinical resolution and resolution on the MRI of the ARIA-E are important. But superficial siderosis is important and something where if you are not comfortable moving forward, may be a reason to stop therapy, but a pause at this point would be appropriate. What would you do, Dave, in this scenario?
She cannot get another one without a repeat MRI showing resolution of ARIA-E and stabilization of the superficial siderosis. The headaches, I would probably treat them with steroids, with a quick steroid taper. Mm-hmm. Because I think that that's enough symptomatic stuff going on that I would want to treat it with a steroid taper, just an oral prednisone taper.
Okay, great. So Doreen and her daughter are uncertain about continuing treatment, being that she's developed ARIA. What would be the most appropriate response to their concern? Tell her that she needs to stay in the game, irrespective of the ARIA? Probably not. Recommend discontinuation since they're concerned. Well, that's giving up or throwing in the towel a little too soon. Defer the decision-making to the caregiver only, given Doreen having MCI. Doreen still can make decisions. She still can change her will too. But it's probably conduct a balanced discussion, talking about the potential adverse reactions, the risks moving forward, but also the alternatives. What would happen if Doreen stop therapy. I think that it's very important that we are very neutral in giving recommendations and giving them very unemotional and very straightforward to the families, allowing them to make those decisions. What do you think about this, Dave?
I couldn't have said it better. It's perfectly said.
So Doreen's been on lecanemab now, twice monthly for 18 months. She hasn't had any further ARIA, and she's here to really discuss the possibility of going to the auto injector after hearing about it. Her mental status evaluation is stable at 24, which is where we started in the first place. So Doreen would like to switch to the subcutaneous form as soon as possible. What is the recommended process of transitioning Doreen from this infusion to the subcutaneous autoinjector? Dave, you mentioned that about half your patients have moved forward with subcutaneous injections. What have you seen as issues for patients?
None. It's a great fit for certain people, especially people who come from a little bit further. Very capable caregivers. Seems like a good fit as well. They're like, oh, I got it. I'll learn how to do it. I got it. No problem. Yeah, I've had no problem with people who adopt the auto injector.
Yes, it's been fairly seamless with us as well, and it's really patient preference at this stage. So what information should be discussed with Doreen prior to beginning the auto injector therapy? And obviously we want to, educate her about how to perform this at home, that, systematic reactions are fairly minimal at this point. We don't do periodic MRIs unless they have clinical symptoms at this stage. And they can do this subcutaneous injection now at home. Doreen is concerned about learning how to administer this injection. Her daughter prefers the idea of injection because it can be done at home and it will decrease her responsibilities taking mom to infusion. How would you navigate the situation? Dave, you mentioned that you have seen Doreen and her daughter before. Yeah. How do you manage this?
I would say you can do it. I have done it. I have done this. It is not scary. You can hold the thing. It looks like an EpiPen. You put it on. It clicks. It's not like a loud click or something alive in your hand. It's very boring. You're going to do the first couple here, and then you're going to go home and you're going to do great.
Exactly. That is wonderful.
Okay, so case number 3, the final case. 69-year-old woman, MCI, taking donanemab, 18 months. Her background, married 47 years, 2 children, 3 caring children. She has benign medical history, hypertension, very well controlled. Her testing is very good, roughly 21. MRI, negative, PET scan, positive. She's ApoE33. She's 20 months into the disease. Okay, so her PET scan after 18 months, amyloid clearance, Centiloid 7. What's the most appropriate next step? I mean, it's pretty obvious. This is stop, right? Because it's cleared, there's no more target. There should be no disagreement on this agent with Centiloids below 11, because that was a cutoff in the trial. Justin, anything else to comment there?
Yes, in the trial, 70% of those patients achieved clearance of the amyloid by the 18-month mark. So we're expecting about 2/3 of those patients to be able to stop therapy.
And she's one of them. So this is a difficult conversation as well, because people are like, wait, you don't mean I don't get the thing that I'm doing so well? And maybe it was because of the dose, but you gotta say, yeah, that's right, we stopped this drug. Okay, so exactly, Gail and her husband expressed concerns that they don't want to stop it. They're concerned. How would you handle these questions?
And, this is very important. The old, if it ain't broke, don't fix it kind of scenario. And we understand this, and we, have shared this being one of the early clinics in the country adopting these therapies. what happens if they decline? And we try to share with the patients that we clinically monitor them carefully, and we always have that option of restarting therapy if there is a concern. But the appropriate answer here at this stage is to discontinue treatment and clinically monitor.
That's exactly right. Be sure to watch our patient session. Catch it early, fight it hard. Thank you, Dr. Moon, for joining me and engaging in this insightful conversation. I'd also like to thank ASI for their support in this important educational activity. If you have not yet watched all the modules in the activity, you'll be directed to the video library page to continue the next module you'd like to watch. You must watch all 3 modules to receive credit for the activity. Click the next button to move on and select the next module you'd like to watch. If you've already watched all the modules in the activity, press continue to continue the post-test and evaluation. Please remember to complete the post-test at the end of the session to secure CME. Visit medlive.com to view today's session along with other sessions. My name is Dave Wiseman. Thanks for joining us.